You're listening to the Blood Bank Guy Essentials Podcast, episode 035. Hey everyone, welcome back to the Blood Bank Guy Essentials Podcast. This is Joe Chaffin, and I am your host. Today's episode is a really fantastic discussion about platelet transfusion with Dr. Rick Kaufman, and we will get to that in just a second, but I first have some really exciting news that I wanted to share with you. My website, which is the Blood Bank Guy site, of course, bbguy.org, and transfusionnews.com, we've joined forces, and we're doing that to try and bring you the best possible transfusion medicine educational content and current news. Transfusion News, I'm sure you're familiar with them. They're a great site, and they provide the latest news in blood banking and transfusion medicine. And they also feature the fabulous Transfusion Medicine Question of the Day, which is a great resource for learning blood banking and transfusion medicine. You can find right now my latest episodes on the Transfusion News homepage, and you can find their latest news updates on mine. So you can stay up to date no matter which site you go to. The most exciting thing for me is that this fall we are planning on launching a brand new educational feature that I just think you're going to love. It's related to this podcast. Again, I can't tell you all the details, but it's going to fulfill one of the most common requests that I get about this very podcast. So please stay tuned, more to come. And in the meantime, you should be aware that Transfusion News is made possible by support from Bio-Rad Laboratories. Now, for today's podcast, as I mentioned, Dr. Rick Kaufman is here from the Brigham and Women's Hospital in Boston. Rick is someone who should be familiar to you. He's published widely, spoken extensively. If you are a longtime listener of this podcast, you'll remember him from May of 2016, where he joined me for a great discussion on the daratumumab effect on our pre-transfusion testing in blood banking. In fact, I've teasingly called him the Dara guy, which I'm not sure he's totally crazy about. But Rick has done a whole lot of other stuff as well, of course. And one of the things that I wanted to discuss with him, he is the lead author on the Clinical Practice Guideline on platelet transfusion published from the AABB in the Annals of Internal Medicine in February of 2015. A very, very interesting discussion and a whole lot of detail. And that's what we're going to get into today. We're going to kind of unpack that Clinical Practice Guideline and give you some really good, I think, solid practical tips on how platelets should be used based on the current evidence that we have today. It's a great interview, and Rick is a lot of fun, so I really think you're going to enjoy it. And with that, I'm going to give you episode 035, Dr. Rick Kaufman. Hey, Rick, welcome back to the Blood Bank Guy Essentials Podcast.
Thanks a lot, Joe. I'm delighted to be back.
Rick, I wanted to have you on again, not just because that Dara podcast was so much fun and actually is still one of the top downloaded podcasts that I have, but you're not just Dara guy, and I didn't mean to just label you that way. You're certainly not. You have a wide array of interests and things that you've published on and worked on. And one of those things is something I've been wanting to do on this podcast for a while, and it's kind of the nuts and bolts of platelet transfusion, and the basics of when we use platelets, when we should and shouldn't use platelets according to the data that's available to us. And you were the lead author on a paper that was published in February 2015 in the Annals of Internal Medicine. It was a clinical guideline, actually called Platelet Transfusion, a Clinical Practice Guideline from the AABB. And in that paper, you guys made, you and the big group that was working with you, made 6 recommendations about platelets. We're not going to go over all of those recommendations because some of them apply to what we're talking about today and some of them aren't. But can you just share with us a little bit what led you guys to think that we needed a clinical practice guideline for platelets?
So the way that the scientific literature gets translated into clinical practice is actually pretty complicated. Mm-hmm. And currently there are so many studies coming out with a wide range of quality, and it's very hard to know at the front lines for an individual physician what the best thing to do is. And so AABB, like other medical societies, decided that it would be valuable to develop guidelines in the areas of those products that are kind of most core to transfusion medicine. So AABB had previously come out with a plasma guideline and a red cell guideline, and they'd gotten a lot of requests, actually over many years, for a platelet guideline. And so anyway, that was the origin of it.
Okay. Well, and one quick question about that. As I mentioned, we're going to cover some of this and some of it we aren't. But I'm always curious how people utilize these things when clinical guidelines and clinical practice guidelines come out. Sometimes I will see people treating these as the absolute dogma, the absolute, like a recipe. And I know from hearing you talk before that you have some concerns about that. I'll just ask you bluntly, how should people utilize a clinical practice guideline in general, and in particular yours on platelet transfusion?
So I look at guidelines as a place to start and not a place to end. That is not a definitive way to treat any given patient or all patients, but as a place to start. And so what they represent is a distillation of the published literature and the best attempt by a specific group to translate that into something simple. Mm-hmm. And it's important, and we point this out in the beginning of the publication, and this is a statement that's true probably for every guideline that's being published now. And we said something like, we don't attempt to address all clinical situations where platelets may be used, and that ultimately clinical judgment and not a specific platelet count threshold is paramount to decide whether or not to transfuse platelets. And the same thing's true for red cells, because we're talking about, ultimately an individual physician has to make an individual decision about a particular patient that he or she is faced with. Mm-hmm. And it's often a very complicated situation, and guidelines necessarily simplify things. Some people would say they dumb them down to something like a platelet count or a hemoglobin in the case of a red cell guideline. But anyway, it's our best attempt at making general advice that then has to be taken with a grain of salt, particularly where the evidence is weak. Mm-hmm. But additionally, really needs to be just one consideration when looking at an individual patient.
Got it. Okay. Well, for everyone listening, I will have a link to that clinical guideline in the show page for this episode, which will be bbguide.org/035, bbguide.org/035. But okay, so Rick, before we get into the specific details about platelets and when we should use them, I think we need to step back for a second. There's going to be people listening to this podcast that have varying levels of expertise and understanding about platelets, and some are just starting in the field. Some may be not blood bankers at all. So just thumbnail it for us, if you would. Why is platelet transfusion such a challenge? What is it about platelets that makes them unique and interesting and strange?
So, yeah, platelets are a really interesting cell. Like red cells, they have no nucleus. They're produced by megakaryocytes within the bone marrow, and will normally circulate for a week or week and a half. And normally they're in a non-activated state, but when needed, that is when there's an injury to a vessel or there's bleeding, they become activated. They recruit other platelets, clotting factors, and are really essential for life to deal with bleeding by forming clots. Mm-hmm. And one issue is that we still don't have a great idea about really how to use them clinically. And once we give them to a patient who's bleeding, there's not a great way to get at exactly what they're doing, other than to look at the patient. Are they still bleeding? Are they not bleeding? And as we'll talk about, most platelets are actually given to patients who are not bleeding, with the idea of trying to prevent bleeding. And again, with any individual transfusion, it's very hard to say, other than looking at the numbers of platelets that are circulating, exactly what's happening in the patient.
Mm-hmm. Okay. Well, what about unique factors in terms of how they're? Is there anything weird about or unique about how they're stored in the blood bank, or how they're produced?
Yeah. So platelets currently are, for the most part, sort of in routine blood bank practice, they're stored at room temperature, and they're stored on a shaker, so they're kept in constant motion to try to maintain the pH of the platelets and keep them happy by facilitating gas exchange with the atmosphere, and they have to be stored at room temperature for a very specific reason. So, in the late '60s, a famous transfusion medicine investigator named Scott Murphy showed that if you put platelets in the refrigerator at 4 degrees for even a short period of time and then transfuse them, that they would be very rapidly cleared from the circulation of the recipient. However, if you stored platelets at room temperature, they would circulate for a much longer period, something like 7 to 10 days. And for that reason, it's been necessary to store them at room temperature. And in order to keep them sort of metabolically happy, as I mentioned, you have to keep them in motion. But then the other, real downside to that is with room temperature storage, there's a real risk for bacterial sepsis. That is, even in theory, one bacterium seeding a bag of platelets at the beginning of room temperature storage can lead to expansion of bacteria in the bag while it's being stored. And so for that reason, platelets are really only good for 5 days on the shelf, and with some types of bacterial testing can be stored for up to 7. But for that reason, you have a product that, unlike red cells or frozen plasma, you have something that's really turning over very, very rapidly. And so it becomes a very tricky, difficult product to maintain just logistically within a blood bank.
So let's talk. Let's get into some of the details. You mentioned just a moment ago the very first topic that we're going to talk about. So we're going to hit 5 kind of major areas where platelets get used, and the one that we're actually going to spend the most time on is the one that is probably going to be surprising to some people that are just starting. And again, you just said this a minute ago that a lot of platelets, in fact, most platelets, are given in settings that could really best be described as prophylaxis in a patient who is not already bleeding. So why don't you take us through that and just give us maybe a little bit of the history of that. How did we even start with that concept that prophylactic platelets might work?
So this really started back in the early '60s and even before. There was one particular study that stands out. It was published in 1962 by Gatos and colleagues, and they looked at a series of 92 patients who were all being treated at the National Cancer Institute for acute leukemia. And essentially the investigators monitored bleeding in these patients who were all made thrombocytopenic. They all had low platelet counts, not because of their disease necessarily, but because of the treatment, because of the chemotherapy that they were receiving. And what they found was as these individuals' platelet counts were lower, they tended to have more days with gross hemorrhage. And they plotted this as a curve in their paper, and there wasn't an obvious inflection point in the curve. That is, it wasn't obvious that under a certain platelet count, bleeding would go up, but it just sort of gradually sort of trended up. But it was clear that when patients got to very low platelet counts, below 10,000, below 5,000, that there was a fair amount of bleeding. And in fact, something like 17% of these patients died from fatal intracerebral hemorrhage.
Oh, wow.
This was something that happened commonly back in those days. It can still happen to oncology patients today, but it's very rare. And they did things a lot differently back then. The chemotherapy that was used was quite different. Those approaches, as well as when patients got a fever back then, they were treated with aspirin, which is a platelet inhibitor. So you wouldn't do that anymore. It's one of the reasons why acetaminophen is used.
Sure.
And so, anyway, there was a decision made that if we kept patients' platelets higher, that they'd be less likely to bleed. And so, right around then, people started using a platelet count threshold of 20,000. That is, if a patient who was receiving chemotherapy had a platelet count that fell below 20,000 platelets per microliter, they would be given a dose of platelets. And in those days, it was actually harder to even get platelets than it is today.
Sure.
But they tried it, and as well as getting rid of aspirin and changing chemotherapy. And bad bleeds became a lot less common. And so that became the standard for a long time.
I see. So I guess, and before we will come back to that 20,000 thing here in just a couple of minutes, and it's really interesting history. So just curious now, though, today, have there been any evidence-based looks at whether or not prophylaxis actually helps?
Yeah, so there have been a total of 3 randomized trials that looked at this, and in recent years there were 2 that really definitively answered that question and showed that yes, so giving patients platelet prophylaxis, even though it's a hassle and expensive, does actually prevent some bleeding and presumably saves some lives.
Okay.
One thing that I will say is that it's still common for patients who are getting chemotherapy or having stem cell transplantation where their bone marrow is suppressed, and so their own platelet counts can become very, very low, but only for a short period of time. That is the expectation after you give someone chemo, is that they'll have a greatly reduced ability to make platelets, but it's temporary. So the bone marrow will recover, and their platelet count, once it crosses a certain threshold, then they're much less likely to have problems, and eventually it should return to normal. So most of the bleeding that people have in this setting is so-called grade 2 bleeding. So this would be something like a nosebleed that lasts more than a half hour, coughing up some blood in the stool. So bleeding that is easily noticeable and maybe actually bothersome to a patient, but it's not bad enough bleeding that you need even a single red cell transfusion. Okay. So the WHO scale is roughly this 1 to 4 scale, and so I talked about grade 2 just now, and so grade 3 would be a bad enough bleed to require a red cell transfusion, and a grade 4 bleed would be something life-threatening, so hemodynamic instability or an intracranial bleed, something like that, or a fatal bleed. And the funny thing about this field, that is, of trying to figure out what platelets are doing and when should we give platelets in patients who are receiving chemotherapy, and you can't actually do a study looking at grade 3 or grade 4 outcomes. That is, they're so rare that it would be logistically impossible and prohibitively expensive to do that sort of study. And so what everyone does is to look at grade 2 or higher bleeding, where it's understood that almost all of the bleeds that we see will be the relatively mild ones that we actually don't care about that much.
Okay.
But anyway, that's what's possible to do. And so a German study led by Hannes Wandt randomized patients who were receiving chemotherapy or having stem cell transplant, randomized them to either get no platelet prophylaxis or to get standard platelet prophylaxis. And the individuals who got no prophylaxis, they only got platelet transfusions if they bled. And they were able to show that there was a significant reduction in grade 2 or higher bleeds. And in fact, they looked carefully for head bleeds among patients that reported headache, and they found that there was a significant reduction in intracerebral bleeds, grade 4 bleeds, in their study. And they actually had 2 deaths in the group that did not receive prophylaxis and no deaths in the group that got prophylaxis. And there was a similar study that was done by my friend and colleague Simon Stanworth, who's at Oxford, and this was called the TOP study. And they similarly randomized patients to get platelet prophylaxis or no platelet prophylaxis in the setting of similar sorts of diseases, patients being treated for leukemia and so on with chemotherapy or stem cell transplant. And they saw similar results. That is, their results were basically in the same direction, and it was helpful to give platelet prophylaxis in reducing grade 2 or higher bleeding.
Got it.
And so based on that, we can say definitively that there is some benefit of giving platelet prophylaxis.
I don't want to spend too much time on this one particular nuance of those studies, but just briefly, was there any difference in terms of why the people were thrombocytopenic? In other words, was any relation to increased risk with a particular disease or treatment?
Yeah, so that's a good question. It turns out that most of the benefit, both in both studies actually, were in patients with acute leukemia who were receiving chemotherapy. Patients who were having autologous stem cell transplant didn't bleed nearly as often, even at the same platelet counts, and that was true in both studies. And so I think that's actually a really important point. I'm glad you mentioned it. So it again gets at this idea that it's not enough just to look at someone's platelet count and be able to judge whether they're going to bleed or not going to bleed. It's very clear, and I think this is a really good illustration of that the reason why someone's platelet counts are low, or the overall clinical context, can really have a big influence on the risk of bleeding. And so I mentioned grade 3 and grade 4 bleeds. We often see them in patients receiving, when we do see them in patients having chemotherapy, they often occur at platelet counts above the level where we would normally be giving platelet prophylaxis. You can have a head bleed at a platelet count of 50 or 100. And so there may be other things going on, inflammation and effects of the conditioning, chemotherapy, that sort of thing. Things that aren't easy to measure and go well beyond the platelet count.
Got it. Okay. That's I think that's a really important point for people to understand. Thank you for elaborating on that, Rick. So, and you guys said this in the clinical practice guideline that the data is clear that transfusing platelets prophylactically is beneficial. But let's go further than that. And I think what you just said is super important, that the number isn't the entire answer, but we kind of do need to have a number as a guideline. So if it is beneficial, which we've said it is, what is a threshold that we might use to determine that cutoff, so to speak, for prophylactic transfusion?
So the original approaches to platelet prophylaxis essentially established 20,000 platelets per microliter as a threshold below which it was considered appropriate to transfuse platelets.
Right.
But as we talked about at the beginning, there's a lot of cost and a lot of logistical difficulty in providing platelets, and there are also real risks to patients. The risks are low, but things like in infectious disease transmission is a low but not zero risk. Particularly when we're talking about bacterial contamination, there are allergic reactions, transfusion-related acute lung injury, and other things. And so we really just want to use platelets as judiciously as possible and try to maximize the risks and the benefits. And so there was an impetus then in the 90s to look at, well, is 20,000 too liberal? Would we get the same results if we used a lower platelet transfusion threshold? And so there were a relatively small number of studies looking at a fairly small number of patients overall, less than 700 actually in total, in some different studies, looking at different thresholds. And the biggest one was a randomized trial published by Paulo Rebula. And essentially it was found that there was not a statistically significant difference in the proportion of patients having grade 2 or higher bleeding among those where a 10,000 trigger was used instead of a 20,000 trigger. And so based on that, in the 90s, it became standard worldwide to use 10,000 as a transfusion threshold. Some places actually use an even lower threshold. There are places that use 5, and there are some data suggesting that in groups of patients, the overall risk of excess bleeding really only rises if the platelet count gets down to 5 or less. But for the most part, because it's actually hard to count platelets on the Coulter counter once the platelet count even gets that low. And also, just for convenience and to give a little buffer, most places use 10.
You will still sometimes hear, Rick, people talking about that there are certain patients that perhaps you should use a higher threshold for prophylactic cutoff. For example, patients that are febrile or septic. Do you have any thoughts on that? Has that been studied, or is that just kind of one of those legends that keeps getting handed down?
I think that's more lore, actually. At least the thing about giving platelets at a higher threshold if patients are febrile. And What I would say though is that if you have a patient who's been getting standard prophylaxis, typically being transfused if the platelet count is 10,000 or less, and is still bleeding, well, that patient, it may be perfectly reasonable to try a higher threshold. So again, it's this idea that for a large group of patients, what we know we know a fair amount about prophylactic platelet transfusion, but there still needs to be room for making adjustments for an individual patient.
Good. Okay. Excellent. I completely agree with that. Okay. So we've answered the first two questions about prophylactic transfusions. A, does it help? Yes. B, if so, at what threshold? And the data suggests that using a 10,000 threshold is reasonable. So what about the one that, quite honestly, most places don't think about, and that is the dose? What do we know about that?
So the platelet dose was studied in a couple of relatively recent studies, and the biggest one was the Plato or platelet dosing study that was led by Cheryl Slichter, who's done a lot of really seminal work in this area of platelet transfusion, particularly prophylactic platelet transfusion. And the idea here was that there may be a need just for a very small amount of platelets to provide a kind of vascular homeostasis. That is, there's an idea that people might develop little injuries to vessels, little bleeds all the time, and you need a small amount of platelets to plug those up. Mm-hmm. And so maybe the doses of platelets that we were routinely giving, and as you know, the AABB standard is that for an apheresis unit, you need 3 × 10⁻11 platelets per bag, and a typical platelet unit actually has something like 4 × 10⁻11. Mm-hmm. And there was also an idea that well maybe we would do better if we gave people higher doses. And the truth is that the way the doses were worked out really weren't done using any sort of clinical trial. And so the aim of the Plato study was to try to figure out, well, is it better to give low dose platelets or higher dose platelets? And so the way the study was set up was that a typical sized patient was given a dose that would be in the range of 3 or 4 × 10⁻11, so kind of a standard single apheresis platelet unit. Mm-hmm. And then patients were either randomized to the standard dose or medium dose arm. Other patients, though, were randomized to receive platelets for a count of 10,000 or less. But they were given platelets in the low dose arm that were essentially half the medium dose, and patients who were randomized to the high dose arm were given essentially double the medium dose. And so what was found was that bleeding outcomes were exactly the same in the 3 groups. So there was absolutely no difference. And so it did actually lend support to this idea that maybe you just need a little bit of platelets to maintain vascular homeostasis. This wasn't really a physiology study. It was, looking at the very clinical endpoint of bleeding using daily bleeding assessments. But anyway, that was what was found. But overall, bleeding rates were quite high. So something like 69 or 70% of individuals in the 3 arms had grade 2 or higher bleeding. Mm-hmm. And one thing that really has dissuaded lots of places from using low dose platelets is that, well, there's a couple of things. So one is you'd have to manufacture them. Right. If it were possible to buy platelets by the platelet as opposed to by the bag, then it might be more cost effective. But right now the providers will sell them by the bag, and so there's no real advantage there. And if you're in a blood bank that manufactures platelets or can divide platelets, well, it's extra work. And then honestly, the big thing is that you have to transfuse platelets more often. So patients in the medium and high dose groups got something like 3 platelets apiece versus 5 platelet units apiece among patients in the low dose group. That is, you could keep them from bleeding at the same rate, mm-hmm. but they would fall below the 10,000 threshold more often simply because they weren't getting as big a bump. And so it was actually less convenient to give low-dose platelets. And so although some places use them and either routinely or if there's platelet shortages, it's not something that's caught on in a big way nationwide or worldwide.
Right. But at least, I mean, I completely agree that the supply of quote unquote low dose apheresis platelets is not widespread. There's not a lot of blood centers that are manufacturing it. Perhaps from the clinical side, one of the take homes that I think is really important to understand that you just hit on is that giving more than a standard dose probably doesn't add any additional benefit, right?
Yeah, so that's important as well. Mm-hmm. So there, I think that's a great point. There truly is no additional benefit in giving higher doses, mm-hmm. and again that would come at greater expense and greater use of the resource. And actually, at the higher doses, patients tended to have more transfusion reactions, more allergic reactions, and that sort of thing. So there was a secondary study of the Plato trial where rates of various transfusion reactions were looked at, and honestly, most of it seemed to track with the amount of plasma that you were giving someone. So from that perspective, giving less plasma, as in a low-dose unit, or at least in a standard dose unit, was better than if you were giving a bigger platelet unit with more plasma in it. So no benefit hemostatically, but more mm-hmm. risk of other things from the plasma coming along with the platelets.
Okay. So Rick, we've spent a decent amount of time talking about the place where, or the situation where essentially 3/4 of platelets are used, and as you pointed out in the clinical guidance, for that we have good data, and you can make a strong recommendation about the benefits of prophylactic platelet transfusion. But when we get into the other 25% or so of how platelets are used, suddenly we're crossing into boundaries where maybe we don't have quite as much evidence. Again, you guys made that point in your paper. So let's start with one of the more controversial places where platelets get used in my personal practice, and that is for minor procedures, for getting patients to certain particular predetermined thresholds for minor procedures, such as putting in a central line or things like that. So why don't you take us through what the evidence shows, such as it is, for things like that?
Yeah, so just to echo what you said about the evidence, it's not immediately obvious from reading the AABB transfusion guideline, but it really is kind of like two guidelines smushed together, where the recommendation 1 covers everything we just talked about. So prophylactic platelets, where there were a large number of randomized controlled trials done over a period of many years that have gotten us to the point where we feel like we have a good understanding of what we're doing, what we can get out of prophylactic platelet transfusion for hospitalized inpatients who've gotten chemotherapy, essentially. For everything else, so the AABB put out five other recommendations, and it's important to look at the even within the abstract, you can see that there's a grade for each recommendation, strong or weak. But the other thing that's judged by this group, and something that readers should really look at anytime they look at a clinical guideline, is what's the quality of the evidence. And for everything else beyond prophylactic platelet transfusion, the evidence was judged to be either low quality or very low quality, and the strength of the recommendation was judged to be weak or in one case uncertain. And so now that we're kind of moving to an area beyond prophylactic platelet transfusion, I can tell you that in a very real sense, we don't know exactly what to do. And so we on the guideline came up with the best recommendations that we could, but we were very careful to, in a really overt way, make it clear that things may change in the future as better data become available, and hopefully better data will. So one difference with areas like the role of platelet transfusion in minor invasive procedures is that there really aren't randomized trial data, well-controlled large studies that support or refute particular practices. And so the best that we were able to do was to look at observational studies. And so you can look at groups of patients who have a certain procedure and have a certain range of platelet count, and then see what happened to them. Did they bleed? Did they not bleed? And in the case of central line placement, our group decided that there was good enough observational data to support recommending a fairly restrictive platelet transfusion threshold. That is, it looked like patients with counts down to 20,000 per microliter or so were really at very low risk to have any sort of bleeding. And then below 20,000, if individuals wanted to transfuse platelets prophylactically to try to reduce the bleeding risk, that was fine. And anyway, that's kind of where we ended up. And for other things, for lumbar puncture, for example, I will say that practices really are all over the place. The strongest data come from a single center, an observational study that was done in children, where several hundred lumbar punctures were done at platelet counts that were below 50, and there were no bleeding events that were reported. However, the very largest observational study that was done in adults that included patients with platelet counts below 50 only included something like 75 patients. And so the group was very hesitant to go beyond a more conservative recommendation of if individuals wanted to transfuse to get a platelet count above 50, that seemed okay. And in the actual text of the document, we say that a clinical judgment should be used for counts between 20,000 and 50,000 in the case of diagnostic LP. And as I mentioned, practices truly are all over the place. There have been a total of something like 21 spinal hematomas resulting from lumbar puncture that have been reported in literature. And of those, the majority happened in patients who had platelets that were below 50,000. So the group sort of had to deal with that one. These individuals had other bleeding risks. And so anyway, bottom line is there really aren't strong data on which to base a recommendation. So we recommend using clinical judgment, but everything else being equal, the judgment of this group was that 50,000 was reasonable. Other groups agree, other groups go with lower or even higher platelet transfusion thresholds. So unfortunately, it's just a tough area.
So I'm curious about since you guys put out this guideline, I'm guessing that you've gotten feedback from multiple different places. One of the things that it seems like, especially your central venous catheter recommendation, is in some conflict with is guidances from different national organizations like the Interventional Radiologists, for example, that, unless I'm wrong, I believe that they recommend pretty much across the board 50,000. Has there been any interaction with that? Any feedback with that?
So there has been some, but only on the level of individual practitioners. We haven't dealt directly with that with the interventional organization. But you're right. So independent of bleeding risk, the current IR guideline recommends 50,000, and we run into it at our own hospital. They don't want to put in a central line if the platelet count's 48,000, and if it's 50, that's fine. And so my feeling is that a lot of platelet transfusions probably are given unnecessarily. That is, I think that it's not clear that this magic number of 50,000 really means anything. But in some cases, clinicians on the floor will transfuse essentially to meet the requirements of their local IR group, who in turn are following the IR guideline. And particularly with in the case of central line placement, I really do think that it's not the best approach for patients or the best use of the resource. Okay. But that's where we are. I would say that red cell transfusion has become more standardized over the years. And again, even with red cells, for which there's many randomized controlled trials, far more than there are for platelet transfusion. Even for red cell transfusion, there still needs to be individual clinical judgments made. But overall, with patient blood management efforts and so on, things have become more standardized. And so my hope is in the future, as data become better, that there will eventually be a kind of patient blood management for platelets, which there's sort of really isn't at this point.
Okay. Well, let's move on to another sometimes controversial topic, and that's the use of platelet transfusion prior to more major procedures. So we've talked about the minor procedures, the putting needles, et cetera, into someone's body. What about when you're actually cutting into someone, like non-neuraxial surgical procedures? What do we know about those?
Yeah, so unfortunately, we know very little. The main published study really is didn't look at a whole lot. It was called the Bishop study. It was published in 1987,
Oh, wow.
and looked at patients having different sorts of procedures, including 29 major surgeries, and essentially it was found that by using a threshold of 50,000, that is, they only would transfuse platelets for patients having major surgery if preoperatively their platelet count was less than 50,000. That in doing these different procedures, they saw intraoperative blood loss that was judged to be over 0.5 liters in only 7% of cases. And so based on that, they said, well, we think 50,000 is good. And that's sort of been a traditional threshold probably before and certainly since. And so, but anyway, I think this is where guidelines become particularly difficult, in that they're really supposed to be based on the published literature in the population that you're looking at. Here, there's been almost nothing since this Bishop studies of 87, but many surgeons are comfortable using 50,000 for things like heart surgery and that sort of thing, and that's kind of where it is right now.
Okay. And you guys did not talk about this in the paper, Rick, but I wonder if you have any personal thoughts that you'd share about, okay, so I said non-neuraxial surgery. What about when they're cutting into the brain? It seems to me personally from my practice that it's a bit of a free-for-all. How do you feel about it?
Yeah, so the neurosurgeons are their own group, and they tend to prefer platelet counts to be above 100,000, and they like INRs that are flat normal, and so on. And so, and this is just how it is. So some neurosurgery groups will perform brain surgery at a platelet count of above 80,000, but most require it to be 100,000. There's really no data, and so that's what we can say.
Okay, fair enough. Well, what about one other major kind of surgery that I think we need to hit really quickly is cardiac surgery and cardiopulmonary bypass. What were you guys able to discover about that?
Well, one of the things that we found was there are some practices that like to give all patients coming off of bypass after cardiac surgery, they like to give them some blood products for hemostasis. And we actually, in the absence of bleeding, we recommend against that practice. Okay. On the other hand, it has been found that patients who are on bypass, they may be cold. It's known that there can be a series of qualitative problems that happen with platelets as they get banged around in the bypass circuit. Mm-hmm. And so, while the platelet count itself may become less meaningful in someone that's been on bypass for a while, they may have a count that's 200,000, but may still be bleeding because their platelets, although reasonable in number, are not functioning as well as they should. And so, right. We think in someone like that, if there's a judgment that there's a qualitative platelet problem, that it's actually okay to transfuse platelets in the setting of even a normal platelet count, mm-hmm. for particular patients. But again, if someone's not bleeding, then we recommend against that.
Okay. All right. So let's move on and talk about another controversial area that was addressed a little bit in the recommendation in your clinical practice guidelines, excuse me, but I think we may have some new information about it. So why don't we talk a little bit about intracranial hemorrhage? That's another area where platelets get used commonly, let me quote what you guys said in the clinical practice guideline. It was recommendation 6, and it was the only place you addressed intracranial hemorrhage. And it said AABB cannot recommend for or against platelet transfusions for patients receiving antiplatelet therapy who have intracranial hemorrhage. So that's kind of a subset. But what are you willing to share, or what can you share? Maybe, I don't want to sound like you're keeping secrets here, Rick, but what can you share about intracranial hemorrhage and platelet transfusion?
Yeah, well, this again gets to some of the inherent difficulties with guidelines.
Uh-huh.
If the evidence is incredibly strong and everyone knows what to do, then a guideline is less useful. On the other hand, if evidence is really weak, then it can be difficult to make a recommendation. In fact, may be inappropriate because you may make a recommendation that's not correct.
Uh-huh.
So this was a case where, for example, at the time there were a small number of observational studies of what happened if you gave platelets to individuals who had an intracranial bleed. And when we actually looked at all the observational studies, essentially we found that one showed that the death rate went up if you gave platelets, one showed that the death rate went down, and the rest showed no difference. And so we honestly could not, based on what was published, could not come up with a recommendation about anything. We could have actually been completely silent about it, but we were getting a lot of questions. Well, what would you guys say? And so we thought that we would just be upfront and say, look, we don't know, we're not sure. And so I think what you were alluding to before was the patch study, which came out last year. So this was a study that was done mainly in the Netherlands, but also in some other countries in Europe, where patients who were on antiplatelet agents, mostly aspirin, some others, if they had an intracerebral hemorrhage, were randomized to standard therapy or standard therapy plus platelet transfusion. And what was surprising was there were actually more deaths among patients who got platelets. And it was a relatively small study, so maybe less than 100 patients in each arm. But anyway, that was the finding. And so with a single randomized trial, sometimes it's completely definitive and changes practice, and other times people aren't sure exactly what to do with it. So that's where we are.
Okay. One more before we move on to some quick thoughts at the end, and that's another place where platelets are being used, I think, more than they used to be, in large part due to the current standard of care in massive transfusion and trauma, and that's in that setting, the use of the so-called 1:1:1 ratio that includes platelet transfusions. What I know you didn't address that in the guidelines, but what can you tell us about the use of platelets in that setting, and what data do we have?
So here I would say that the data are the strong data are really quite limited. So for example, we don't have a randomized trial of treating trauma patients with or without platelet transfusions. And such a study will probably never be done. It's been said, for example, you can't do a randomized trial of parachutes. Like so there are some randomized trials that simply cannot be done, and I would say that would be one. And so, on the other hand, I think that there's broad acceptance that following a trauma, many patients do seem to have a pretty complicated coagulopathy, and there really is likely to be benefit in providing platelet transfusions. And one thing that I would say is that there's still uncertainty about what's the absolute best way to manage trauma patients, that sort of thing. But I think lots of places have found that having a simple and rapid approach, independent of exactly how you're treating the patient, is itself a benefit. And so simply in a pragmatic sort of way, right, where perhaps a single phone call can be made to the blood bank, and in patients who really are having very, very severe bleeding, that having a process where it's possible to provide lots of products in a hurry and in a way that everyone will understand what they're getting is beneficial. And platelets really should be part of that. One side note, though, is that this one-to-one-to-one business, so it refers to one platelet unit, one plasma unit, and one red cell unit.
Mm-hmm.
In that ratio, some places like 1:1:2, but giving half as many platelets and plasma as red cells. But it's important to understand that 1:1:1, when it refers to platelets, is referring to a platelet concentrate.
Right.
So I have seen some places that were giving out one apheresis platelet for every one red cell unit, and that really is not what the approach is meant to do. So it would be more like 6 red cells, 6 plasma, and 1 apheresis platelet unit, something like that.
That's I thank you for bringing that up. That is a common point of confusion. I completely agree. Okay, so in the time that we have left, Rick, I want to get your just kind of quick thoughts on some things that people ask, and I think it's I think these things are important, but we don't have a ton of time to go into them. So let's get your quick thoughts. The very first thing that people are discussing more lately, and this may not be a topic that can be adequately covered in a 1 or 2 minute answer, but let's give it a shot, and that is the use of out of group platelets. I don't think anybody would argue that giving someone a perfectly ABO matched platelet is probably the best choice. But unfortunately, due to supply constraints, that's not always possible. So your personal thoughts on out of group platelets?
So we do this. We try to avoid it. It's very clear that if you give an ABO major mismatch platelet transfusion. So if you have a recipient that's type O and you give them an A platelet, it was shown really many years ago that at least those platelets that express high levels of A antigen, and there are ABO sugars on platelets, so those platelets get cleared essentially immediately, very, very quickly. And so by giving an A platelet to an O recipient, you're essentially giving a somewhat lower platelet dose. As we talked about with the Plato trial, that may not matter clinically, depending on the situation. So you're right. Everything else being equal, yes, for a variety of reasons, you'd like to give ABO identical. On the other hand, what we really worry about is the opposite situation, a minor side mismatch where you would give an O platelet to an A recipient, say. So here you're giving some anti-A along with the platelets themselves, and the rate of hemolytic reactions is not really known. It's thought to be something like 1 in 10,000 patients. And so for this reason, in Great Britain, they have a standard where they'll titer for anti-A and anti-B, and only give out-of-group platelets for units that are below that titer. Mm-hmm. And we've tried something similar at our own place. We have a single, we use a titer of 200, might be a little high, but we've seen units of platelets that for whatever reason, every once in a while we'll give an out of group, usually type O platelet to an A or B recipient, and they'll have a significant hemolytic reaction. It's not as bad as giving an ABO mismatched red cell transfusion, but you can certainly see a drop in hemoglobin of 2 or 3 grams or more sometimes. And so that's anyway. That's just a real, although rare, risk of this practice. And I think this is something that we see probably with our current practice, even doing titers, probably once every few years, something like that.
Okay. And of course there are some in our field, some very prominent people in our field that believe that interaction can cause some even further deleterious effects on recipients, but we probably don't have a ton of time to get into that. So let's move on to the next one, and that's washing platelets. And that kind of goes to what we were just saying. Washing in that setting where you're doing the so-called minor mismatch and giving the O platelet to an A recipient. Some would say, well, heck, let's just wash it to get rid of all of that plasma. And I've heard you talk before about some of the benefits and the trade-offs of washing. How do you feel about washing platelets?
So sometimes I think it's really important. Aaron Tobin and Will Savage and Paul Ness published a really nice study in 2011 that showed that among patients who had either recurrent allergic transfusion reactions, or a really bad sort of even one anaphylactic reaction to a platelet transfusion, some really atopic individuals, it was definitely helpful to wash platelets. You could reduce the rate of allergic transfusion reactions. In their study, it was something like 5% to 0.7% by washing. And so really what you're getting rid of is, well, a lot of things, but presumably the main thing is protein antigens that people may be allergic to, that are in the plasma. Now, by washing, though, you are losing some of the hemostatic function that you like to provide. Whether you're concentrating, that is taking out some of the plasma, or really washing, like in a cell washer, you will cause some of the platelets to be lost and beat up, and so effectively you're giving a lower dose of the platelets. And again, if it's for prophylaxis, it's probably not something that you could see as in terms of a difference in bleeding outcomes. But anyway, that's the story.
Okay. A couple more real fast. What about, this is something that I'm hearing from, especially from people involved in trauma, and that's, you mentioned before that platelets, when they're stored at colder temperatures, they don't last very long in terms of circulating in the body. But there are some who are talking about that and saying, well, so what if they do a quick job, for example, in a trauma, why not have them as cold stored? Do you have any thoughts on that, cold storing platelets?
Yeah, it's an interesting area. There's a couple different approaches. So one are actually things like frozen platelets. Freeze-dried platelets are sometimes used in, or being looked at in military situations. The Dutch have been using these, for example, and they're being studied here. But it is possible to store platelets in the cold in the refrigerator. When you do that, you actually don't even need to put them on a shaker. They don't metabolize nearly as rapidly. And when you test them in vitro, at least by many in vitro tests of hemostasis, of their ability to clot, aggregation studies and so on, they actually do much better than room temperature platelets. And so Andre Kapp and others have been actively studying these, and it remains to be seen what's gonna happen. I think it will be necessary to demonstrate a real benefit and real safety among patients who are bleeding, getting chilled platelets, and it's possible that there may come a time where we have room temperature platelets for patients who are getting prophylaxis, where they probably weren't going to bleed, but you want to reduce the risk that they will, and so you're just trying to keep their count at a certain level in the non-bleeding setting. And some other platelets stored in the cold that would be intended for patients having a trauma or severe bleeding and surgery, that sort of thing. And then finally, there are approaches that have been taken, and this is still an area of investigation. Is there a way that platelets could be modified to get the best of both worlds, be able to store them at under refrigeration and also have them circulate for a normal amount of time? So I think that those studies will continue.
Nice. Okay. One last thing for you, Rick, and this is something that, well, honestly, people freak out about sometimes, and I think we have some data on this, but I wondered if you would share your thoughts on the times when you are forced, generally through for supply reasons, to give a Rh positive or D positive platelet to an Rh negative, D negative recipient.
Yeah. So right now at my institution, we're using all apheresis platelets. And it's known that modern apheresis platelets really have a very, very small load of contaminating red cells, just microliter amounts. The world record for stimulating anti-D in someone through a platelet unit seems to be about 30 microliters of red cells. And so it's certainly possible with an apheresis platelet unit, but it's rare. And so the approach that we're currently taking is we actually don't worry about it in males. With female recipients who may have childbearing potential down the road, we do recommend a dose of Rh immune globulin, which will reduce the really low risk, less than 1% risk of anti-D formation to zero. And this is something that, well, different places handle differently. The only thing I would say is that for places that are using uh, pools of platelet concentrates, there can be higher and more variable red cell content in those. And so the expectation would be that the sensitization rate may be higher, and it may be more, maybe more reasonable to use arginine globulin in that setting. And then the last thing is that our transplanters don't care much about this issue, and what they have found is that a lot of the patients who are receiving platelet transfusions are very immunocompromised and maybe less likely to form antibodies like anti-D than other patients. But that, anyway, it's as I was saying, it's practices kind of vary around this.
Well, Rick, we have taken quite a tour through the sometimes wacky world of platelet transfusion. Thank you so much for being with me on the podcast.
It's my pleasure, Joe. Take care.
So I just want to remind everyone that if you go to the show page, that's bbguide.org/035, you'll find a whole bunch of resources there for your viewing pleasure, including links to many of the articles, if not all of the articles that Dr. Kaufman mentioned in the podcast today, some slides that Dr. Kaufman has used to talk about the clinical practice guideline in the past, and at least as important as any of that is the comment section. I do read each and every comment that comes in, and I interact with people all the time on the comment in the comment area on the Blood Bank Guide page. So I hope that you would take that opportunity to interact. Let's talk about it. Also, if you would head over to bbguide.org/subscribe, you can get on my email list, and you won't miss any of the cool stuff that is coming down the line. And please, one other reminder, the next time you're on a computer, just open up iTunes and give this podcast a rating and a review. Once again, it just helps us get the podcast in front of more and more people. Well, my friends, that is it for today. I want to thank you just one last time, and to remind you that as we close, I hope that as you go through your day today, that you'll smile, that you'll have fun, and above all, never ever stop learning. Take care. We'll catch you next time on the podcast.